Good afternoon, everyone. I think we might make a start to this afternoon's event. Thank you, everyone, for attending and logging in. My name is Jenny Phillip, and I'm the Chair of Palliative Medicine at the University of Melbourne and St Vincent's Hospital, and it's my great pleasure to welcome you all here to this very special event that we have this afternoon. Today's event is being hosted by Palliative Nexus, which is a research group who has a particular focus on improving the quality of care and the quality of palliative care such that it's equitable, timely and delivered as a standard of care and underpinned by evidence for all people with advanced illness. So I'm proud to be hosting this and proud to welcome you here today. To begin, I wish to acknowledge the traditional custodians of the land in which we're all on in our separate corners of the state and perhaps of the country today. Today, the land on which we're hosting this event is that of the Wurundjeri people of the Kulin Nations, and I wish to acknowledge their elders past and present. I also wish to acknowledge any Aboriginal Australians who may be in the audience today. I'd like to just take a step before getting into our main event today to just ask for your, I guess, for a moment. I think many of us, myself included, are watching the COVID crisis with in India with great sadness and sense of helplessness and horror at the suffering that we're witnessing and the catastrophe that's unfolding. And I know that many of us are feeling helpless and would like to help. And I guess we have had some discussions, those perhaps in the audience who have colleagues in India, and indeed I see that Dr. Das is joining us from India today. If you would like to perhaps donate to Pallium India, which is an organisation in India which is very committed to improving the palliative care of people in India. Pallium India has relationships with Apply, which is based here in Australia, and Apply is a charity that has the purpose of relief of suffering through mentoring and supporting professionals and others who are working in low and middle income countries. Apply has relationships with Pallium India and has agreed that that they would be doing fundraising to be transferred or to be supporting Pallium India in their efforts in response to the COVID crisis. And if I could just say a couple of words, that Pallium India has increased its community outreach during COVID and has ongoing commitment to supporting the disabled, the elderly and those with advanced illness. They are seeking to assist in all sorts of basic care and also have established a helpline and bereavement and grief counselling line. And just to read a few lines from Dr. Raj Gopal, who's the director of Pallium India. And I quote, "With the surge of COVID-19 in April 21, we see concentrated suffering again. We see a growing number of people in intense grief from the loss of a loved one. We see vulnerable people, those living with disabilities, the elderly, and other marginalised populations denied basic health care. How does the auto rickshaw driver look after his ailing parents when he no longer has an income? What do you think happens to villagers who can no longer get their blood pressure checked or their diabetes treated? When access to healthcare is reduced as a whole, who do you think is most at risk? Indeed, it's the poor wage earners who earn nothing anymore, and also the elderly and those living with disabilities, rich or poor. We now see hundreds more with health-related suffering than we did 1 year back. We have to compensate for the reduced access to primary care. And would it make sense if we dish out tablets and leave them without food? The need is huge, but we are determined to try our best." So if you would like to help, as I said, Apply is fundraising for Pallium India until in June, and all funds will be diverted to or transferred to Pallium India to support them in in their work. And I guess just to know that donations over $2 are tax deductible. So thank you. And I'd like to now move on to the main event for today. And it is my very great pleasure to welcome Professor Bruce Rumbold to In Conversation. Bruce is known to most of you, I think, having been a leading thinker and advocate for palliative care for many years. He's Associate Professor in the Department of Public Health and Director of the Public Health Palliative Care Unit at Trobe University. The unit works collaboratively with health services, community groups and other academic programs in a number of community capacity building projects on end-of-life care. Bruce's multidisciplinary interests are supported by postgraduate qualifications in physics, practical theology and health social sciences. Before joining La Trobe, Bruce held a position of Foundation Professor of Pastoral Studies at what is now known as the University of Divinity in Melbourne. And his current work is particularly focused on the social determinants of end-of-life experiences, forming and sustaining compassionate communities and spiritual care. And it's my very great pleasure to welcome Bruce to be our person on the couch or interviewee today. So welcome, Bruce.
Thank you very much, Jen. Yeah.
So Bruce, I wonder if you could talk about your academic interests. And what I didn't say in your introduction is that you have a Master of Sciences, 2 PhDs, a Bachelor of Divinity and a Master of Arts?
Something like that, yes. I mean, in my defense, it's really, it's a misspent youth, but I mean, I knocked most of that over by the time I was 30. So, you know, I was slightly ahead of the baby boom, so I got shoved through school very quickly and was at university by the time I was 16 and sort of filled my time in, well, mucking around while trying to work out what I was going to do when I grew up. And unfortunately, I'm still puzzling a little bit over that particular issue.
So it's a parental dream, isn't it? A misspent youth to be all those degrees.
Possibly. Well, yes, prior to fee paying anyway.
Yeah, that's right. So Bruce, tell me, I mean, so each of those degrees, tell me what it was that made you do each one of those. What was the thing that really gave you the itch to do each of those individually?
I mean, sometimes it was a failure to avoid the consequences, I suppose. But I mean, when I look at them, they're all big picture things. They're all about how do things hold together and how does the world work and all that sort of stuff. So that, I mean, perhaps ironically, I went to university determined to drop physics, but they put me on the honours stream and I didn't have the initiative to get out of it. So I did a master's at Melbourne, which was largely about what I would have done had the equipment arrived from America in time. And then went to Monash to finish off there. And I guess I had a supervisor who could think in quantum space. He was Jeff Wilson. He was just brilliant. And that made me realize that I could be competent, but I was never going to be like that. And I was really interested in a lot of other stuff as well. And somehow I found myself doing theology and ordained as a Baptist minister, decided I better even it up by going to England, Manchester in the early days of the hospice movement and ended up working in hospice there. And then I came back to do 10 years of parish ministry before I started at the theological school.
So the move from, do you want to comment on the move from physics and all
physics
the
to metaphysics
to theology? I think that's an interesting but possibly very aligned sort of pathway.
Well, I mean, that's right. They're around about systems of meaning and how does the world hold together and what makes sense and what sort of questions can we ask and what happens when we ask particular sorts of questions. And I suppose the thing about physics is in its fundamental structure that the idea as the experimenter or the questioner, you are embedded in what you find out. You ask one sort of question, it determines the sort of answer you will get. And you realize that you cannot actually get your head around all of reality. And so you have to build models and work with the way those models approximate reality. So everything is preliminary and tentative and negotiable. And I guess in a sense, that sort of form of discovery, that sort of the sort of thinking that's involved in that was what actually interested me increasingly in theology, and then in due course in sociology, in a way.
So the types of conversations and the type of methods that you use almost are aligning. Is that what you say?
They align, yes, that's right. And sociology, in a sense, actually is a nice intermediate strategy between them, because you ask the question as a sociologist, not only what's going on here and how can we understand it, but you also ask the question about what else could we be doing? So what's been marginalized? What's been excluded? What's absent in this sort of situation? So you're into building worlds and alternate worlds so there's a lot of play in it, I suppose, in some ways, but it's also fairly serious business when you try to work out how do you actually implement that stuff where you are, with the responsibilities you've taken on, with the people around you.
Yeah. So you took although some of that learning I'm still thinking might have happened later, but you took all of that big thinking and those big questions over to the UK when you were in your 20s, I'm guessing, perhaps in the mid-20s.
I was indeed, that's right, yes.
So tell me what it was. Actually, before we get into all of that, tell me what it was like being in the UK in the mid-70s.
Well, it was good. It was interesting. We were in Manchester, so that was really right off the tourist track in those sorts of days. That's the unfortunate thing was that I arrived in England just after Monty Python had done the Wollongong School of Philosophy sketch.
Yeah.
You know the one, Bruce, this is Bruce. So to be introduced as an Australian called Bruce would have people sort of rolling around in the aisles. But having got through that particular thing, I suppose, it was an interesting time to be there, I suppose, because looking back on it, intellectually, there's a lot of stuff that was in flux. There was a whole lot of collectivist and communitarian thinking turning up all over the countryside. There was equally a whole lot of reaction to it. And so there's a lot of debate going on. I mean, I suppose one example would be, the debate between psychiatry. Is it a storefront discipline or is it something which is biologically determined? And of course, as we know, DSM-3 won out over that particular debate and took psychiatry in a particular direction. But there was a lot of stuff up for grabs in the 70s.
It's very exciting. And of course, you were part of a big group of young intellectuals who left for the UK. I think they called them once the Brat Pack, didn't they?
I think the Brat Pack was about a decade before me, I suspect.
Was it?
Yes,
Okay.
That's right. Yeah. The Clive James and Germaine Greers of this life.
Yeah,
yes,
and the Robert Hughes and such.
Yes, that's right. Yeah.
So when you were there and you were hearing all these big conversations, then palliative care was sort of put under your nose? What was it about that?
Well, yes and no. I mean, I actually became interested in the death and dying stuff as it began to emerge. I mean, as a physics postgraduate, I read John Hinton's little book on dying, which came out in '67 somewhat. And, and Hinton's sort of argument was, well, one of the classic quotes is the dissatisfied dead cannot noise abroad the negligence they have experienced. And he was, so in a sense, he was setting a scenario in which Cicely Saunders was doing the practical work in the background. And when I was doing honours in pastoral theology, that was in the very early days of Elizabeth Kubler-Ross's stuff, which was starting to thing. And it began to interest me that there was all this new writing about death and dying, and somehow the church still seemed to be seen as experts because they still did all the funerals. But I thought about it, and in my 25 years or whatever, I had never in my life heard a sensible sermon about death, about the human experience of dying. It was usually used as a club to, the sort of business. Realize if you leave the meeting tonight, you may be run over by a bus sort of strategy. I mean, come on. So when I was looking for topics to explore, that was one of them. I took across to Manchester and very quickly discovered that there was a local hospice being set up in the area, and so aligned myself with that, and was in on the early days of St Anne's Hospice in Cheshire, which was a little 32-bed inpatient job, which I think was 28 beds cancer, 4 beds neurological conditions.
Mm-hmm. And so you sort of just said it in passing, but what was the reaction when Elizabeth Kubler-Ross's book came out? What do you remember of that? Because even now it's still, I mean, that people argue and critique it sort of to death.
Yeah.
However, it was highly, important, or high. There was a before and after.
Look, it was really important, and I think, but for me, the importance was that it actually demonstrated you could talk to people about dying, and you could talk to dying people about dying and have a sensible conversation. Well, reasonably sensible. Looking back on it, the Kubler-Ross stages stuff is nothing more than an adjustment process. I experienced the Kubler-Ross stages when I used to drive into the city. I can't believe that the slip road's jammed up. What's going on? If I can get into the third lane, you often get a better run. That sort of stuff. It's this whole business of response and adjustment. But as I said, the strength of it was the idea that you can talk. She opened up the possibility of conversation. And I remember doing the literature review in the mid 70s, or actually 74, I suppose, when I started, that there were literally thousands of repeats of Elizabeth Kubler-Ross kicking around all over the countryside in every discipline's journal. Didn't ever take it much further, but nevertheless, it opened up a topic of conversation. And that was the power of it, I guess, the beginning of a new conversation.
Yeah. I mean, in a sort of a minor form now, when we see other parts of the world, but last year in Melbourne we saw all those stages sort of unfold, didn't we, through to the anger and the bargaining and such.
Yeah, that's right. How do you adjust to changes in your life? It's it's the way we do it.
Indeed. So Bruce, tell me about, so from your as I read out at the beginning, you've got sort of, I guess, a few key areas of interest and research interest at the moment. I wonder if you wouldn't mind talking about each of those in turn, maybe about what attracts you and what you feel is interesting that you found out about it. So perhaps the social determinants of health, of end-of-life experience in the first instance.
Well, I mean, I suppose the social determinants of health is the big frame stuff, which continues to interest me particularly because we've got a lot of good insights into how to build healthy societies, but it is not possible to do so simply by bolstering and funding the health system, which is actually an illness system. So we do illness care really well, pretty well, but in actual fact, to produce health, we need to do so within communities, and we discover that the healthiest communities are the ones in which social inequality is addressed, where social inequality is reduced, where social inclusion is fostered, where people find strategies for caring for each other. So that's the sort of stuff, I suppose, which interests me, partly because it's really where the pastoral care stuff comes out of, the idea of mutual care and care in community, and care which is based around some sort of shared meaning and purpose. So I better not disappear down too many horizons on that. But when we look at, say, take a social determinants approach to end-of-life care, we ask ourselves the questions about who is being cared for and who's missing out, who gets in and who is excluded, where are the inequalities in the system. And we realize pretty quickly that in actual fact, we provide excellent care to a fairly small proportion of the population, and pretty good care to another 10, 20, 30%. But we still, in terms of end-of-life care, and after all, 100% of us still die, there's a lot of people still missing out. And so we have one of these debates that's going on at the moment, I think, about, are people missing out because palliative care is insufficiently resourced? Can we push our model out in a way which will embrace everybody? Or do we need to start somewhere else and ask the question about what is a good death and where does palliative care fit in with the sort of end-of-life care that the whole of the society needs. And I guess my money tends to be with that second question a little bit more, while never wanting to run down or denigrate the contribution of palliative care as a discipline in itself. But as a discipline, it tends to be trapped within healthcare. And that illness system is not capable of realizing health and excellent care and transform societies on its own. Gosh, I'm sounding like a preacher, aren't I?
Yeah, that's right. Old tropes.
That's right. Yes, get it back.
So what would health at end of life look like?
It would look like people. Oh gosh, I mean, this inevitably. I suppose we start to talk in ideals. But people being able to die within their communities, within their households, within the networks of people who care about them, knowing that they're looked after, knowing that they've loved, knowing that they've made a contribution, knowing that aspects of that or elements of that contribution will continue so that they will live on in the lives and the minds of others, so that their life has counted and that their death will count as well. And I suppose, I mean, some people achieve that, but lots of people don't because of the fragmented way in which we offer care today. And I mean, part of that, I think, has to do with the fragmentation and specialization of our healthcare system and the decision that we have made as a society that dying is something that health needs to look after, rather than recognize that it is a responsibility of the whole of our society. And that we need to be able to partner with healthcare as citizens, rather than handball the whole lot across into the healthcare system. I mean, that was really one of the earliest studies of contemporary or modern death and dying was back to Glaser and Strauss back in the days when they invented grounded theory out of that particular experiment or study. And one of the things they found was that society had basically decided to hand over to the healthcare system an overwhelming burden of emotional work, and that by and large, most healthcare systems were probably even less skilled than the general population to handle that burden, partly because of the sort of ways in which we find out the sort of way we choose our professional roles. In other words, we often choose to work with the things which are the greatest problem for us. And so, speaking as a man who has problem with death and religion, that's probably
but not
where I end up. No, that's right. I've moved on from that. Yeah.
So, Bruce, just before we leave that though, can you talk to me about in the ideal, because obviously the healthcare system needs to, continue, like it can't have no role. And I know that's not what I'm suggesting. But what would be the best sort of, like, how would it best fit together?
Well, it seems pretty clear from all the evidence which is around at the present moment is the best care is provided when formal care and informal care systems can work together in some sort of way. And that, we have various models or pictures of that being achieved, but it seems to me that one of the problems of professionalism over the last century is that we have worked so hard to draw a line between professional and citizens and other forms of professionals that we have a great deal of trouble trying to transcend or move over those boundaries. And when that sort of collaboration between the formal and informal works, it usually happens because of what the German psychiatrist Klaus Dörner calls a third social space. Situations in which people can meet up in a way which allows them to move outside or transcend their roles and collaborate as fellow human beings, but nevertheless are accountable to each other. It's not a sort of a rule-free space. It's a place where people recognize what their contribution is and are able to make it in collaboration with other people. And so I'm sort of rambling on a bit or a bit vague about that. But I mean, for example, it makes me wish that when palliative care services say what they do, they would also be very clear in saying what they can't do.
Mm.
Because I think we still get into a lot of problems of people who hear that palliative care is this wonderful system that provides impeccable care and all sorts of forms of support. And then people get into it and they discover they can get a couple of visits a week, and that when they ring up after hours, they're diverted to somebody who doesn't actually necessarily know them, and et cetera, et cetera. We need much better clarity about what we can and cannot offer, in order that we can then go ahead and sort out how do we fill the gaps that the stuff which one group can't offer can be met by another.
Mm. Mm.
Sorry, that's all again.
Yeah, I guess, yes, no, and it's an important bit, and I guess in some way the palliative care formal healthcare services have been needing to convince healthcare and the community of their importance and role, and perhaps in that there's the risk of over-promising.
Yeah, look, I mean, I think that's almost inevitable. Those of us who come from helping professions are continually tempted to do it. And I mean, in an ironic way, I think one of the things we have to learn to do is to give up trying to help people in order to be useful. And to understand that, I cannot save this person, but I can contribute this. And I have to trust somehow to the system, to the life, to the universe, that the needs that I cannot address will be addressed by someone else. So it's sort of humility or modesty or something in care, is it? I don't know. Yeah. But of course, our systems drive us all the time to go to the boundary, but also often beyond it.
Yes. No, thank you. It's been that's very thoughtful sort of, I guess, reflections, and also, loops back to, the initial big thinking that we were talking of. Bruce, you've worked in the field for a long time and have witnessed lots of things.
I have indeed.
Yes. Over the years. What have you been most struck by? The big things that you've noticed, if you were sort of standing back and thinking, gosh, this is this field of palliative care, public health palliative care, the end of life sort of domain. What things do you think is most marked, or what things strike you?
Oh, that's actually rather difficult to answer. I mean, obviously, one of the things that strikes me is the success that palliative care has had in actually beginning to join with the health system. But I also see that has been a problem. So this is the typical ambivalence of the physicist, really. Is it a particle? Is it a wave? No, the little bug is both, sort of thing. And so while I would want to applaud the way in which palliative care has established itself within our care systems, I also see, I suppose, the problems of it, which is where the public health approach hopefully comes in. But the trouble is, most of our systems are we juxtapose things all the time rather than integrate them. And so to
what
start
do you mean
to talk,
by juxtapose? To talk
well,
to that?
we sort of often talk as if there's a choice between clinical palliative care and public health palliative care or community development approaches. But in actual fact, one needs the other. You can't provide good care in the community if you don't have clinical services who are available and collaborating and being an intrinsic part of it. But similarly, you don't actually have good clinical care or impeccable care, use the dreaded WHO word, if we don't have community involvement in some way or another. And my sense is that we have still not worked out how to be intentional about that, which is what a public health model attempts to do, to work out strategies. But again, the problems come at the level at which we still want to run, it seems often, with very much generalizable stuff, but public health solutions tend to be local.
Mm.
And so the capacity to endorse and to fund the local and to trust people to come up with a good solution is what undoes many of our attempts, including our attempts in Indigenous health. Trusting the community is not a very popular strategy.
No, yes, I was struck by the parallels as you were talking. So what things haven't changed and the things that you think we should hang on to?
I think we should hang on to the original hospice idea, which was that that end-of-life care needs to deal with whole people and whole situations and whole networks, I suppose. I mean, the public health thing takes it from the family focus of, say, Cicely Saunders, to say we actually need to look at people and their social networks, their extended networks that support them, which nowadays are a mixture of virtual networks and geographic and what else, a glorious sort of mess of things. So I think we do need to hold on to that. I also do need to think that we need to begin to celebrate the generalist rather than the specialist in most areas of life. This is a bit of an outsider comment, but I mean, one of the things that strikes me that when I started off working in this territory, we used to have physicians. You know, the people who were sort of integrative animals who you could actually go along to with chronic, complex problems, and they'd actually know how to start to sort things out. They had an integrative approach. The physicians seem to almost disappeared within our system. Although I think we are beginning to see some of them coming back as specialists start to realize they actually have to reach beyond their particular expertise and start connecting stuff up again. Sorry, I'm distracted, but what am I trying to say? Yeah, so we have worked very hard at specialized knowledge, and I think we have often lost sight of the linking stuff, often the common sense stuff. Because one of my observations would be that often in the healthcare system, often one of the first things to disappear is common sense. Which sort of actually reminds me, back in the hospice, I went back to St Anne's Hospice to sort of convey some of my findings to the staff, and I sort of was getting about helplessness theory and all this, all this highfalutin sort of stuff. And finally, one of the nurses, who'd actually was a retired hairdresser, said to me, "Oh, you mean patients are just like people, really?" That was it, really.
Well, that took the wind out of the sails.
Well, I thought it was a wonderful insight, though.
Yeah. Yes, I as you were talking, I was thinking that perhaps we don't value the in-between bits, you know, maybe the third spaces and the networks as much as we should, those bits that link us all and that we share.
Yes. Because I mean, I think, you know, as a parish minister looking after people living their dying in the community, you soon heard about the specialists who were able to make a human connection and how powerful that connection was. The person who said, "How are you?" and actually meant it because they were actually inquiring about the illness experience, rather than the person who says, "And so how did the last, treatment go?"
Yeah.
Incredible difference, because the power of being greeted by a person would keep people afloat for weeks. Absolutely incredible stuff. So even that very simple thing, the joining in the third social space where we're all humans together, strikes me as being one of the real gifts that a professional can give. And it costs a bit, but it also actually nourishes the person rather than as well as builds us up as a community.
Yeah, thank you. Yes, I agree. So Bruce, we like to as we're getting towards the end of this discussion, we like to float a quotation, and I'd like you to sort of reflect on it and comment on it. So this is from M. Wilson in the
Michael
1970s.
Wilson.
Michael Wilson.
Yes,
There's no
yes.
way to health through the cure of illness. Rather than trying to reach health by understanding illness, we must first try to understand health, in the light of which we may be able to say something about being well or ill.
Look, I think that sort of harks back to some of the stuff I was wanting to say, that, you know, if as we begin to understand health, which is in some ways one of the ideals of a public health approach, we understand that the care or the cure of illness is only an aspect of it, but that the issue must be addressed in all sorts of ways. So, in a sense, the problem-oriented approach goes wrong. Well, it goes wrong at the level of that old medical school quotation: "There's no such thing as a healthy person, only an under-investigated one." Or you see it, or you see it in psychoanalysis, where in a Freudian system, you can't be well; you can only be a little bit less sick. And obviously, we have moved beyond those sorts of perspectives to understand we actually have to look at wellness and health, and how our activities toward cure and treatment actually fit within that. And maybe, for example, in end-of-life care, we had a better idea about what healthy dying was, we might be able to make some better decisions in care in end-of-life care, rather than have this situation, which I think happens too often, that people come to the end, often damaged by the treatment regimes to which they have been exposed or which they have chosen for themselves. And they end up with a really messy end of life because the decisions hadn't been made earlier, because they didn't have a horizon or a perspective within which to make it. And that's pretty idealistic, I know, but in a sense, if as communities we can start to talk more about some of the stuff and some of these values and some of them, then maybe we can actually we actually give palliative care the tools to work with to help people to make those better decisions.
So, Bruce, the final question, and I'm just going to ask if Tanya's there, I'm just going to ask her to pop up the slide that you shared with us. I don't know if you knew that we were going to make it public.
How ominous.
Yeah. So I'm not sure. Thanks, Tanya. So I'm sure that the audience can see that and can reflect on those years since the 1970s when you went to the UK. But if you think back to that young Bruce in the 1970s, what advice would you give to your younger self?
Oh, yes, he does look very young, doesn't he? PhD candidate in physics in those days. What advice would I give? Look, I really don't know, because in some ways that's almost like a question about what do I have regrets? And no, but in some ways,
no. What are you wiser now, probably? Yeah. And what things do you think?
I realise that my interests, and I have always positioned myself between, on the edges of a couple of things, and in a sense tried to operate between those two spheres. Maybe I would tell my younger self to trust some of my judgments more and move a bit quicker. I mean, did I accidentally do a PhD in physics? Maybe not have been the best move, as it were. And here I am 10 years past retirement, still hanging around trying to work out what I want to do. But
when you grow up,
maybe the advice I would give is to stay curious.
Yep. That sounds very fine advice indeed. So thank you, Bruce. So we might go back to the big screen. Thank you. Thank you for that, Tanya. So it's my great pleasure on behalf of all of us and of the audience who have been chatting away on the side and reflecting and picking up some of the key comments and pearls and ideas that have really resonated with them, Bruce. So thank you for joining us today and giving us just a taste of your wonderful thinking and your intellectual breadth and your rich and humanist approach. And we're very grateful for all the work that you have done, continue to do, and also for sharing it with us this afternoon. So thank you, Bruce.
Oh, thank you, Jen, and thanks very much for having me.
Yeah.
Thank you.
And if I could also thank the team behind the scenes, which is Stacey Panozzo and
There they are.
Tanya Fraser, for all the work and making this all come together. So thank you very much, Stacey and Tanya. And I wanted to maybe alert you to our next, sorry, I've just seen Bruce's screensaver. I wanted to alert you to our next event, which is going to be, I've forgotten the date actually, but here it comes. Our next event, which is going to be showcasing some of our junior researchers or our emerging researchers. We're hearing from Dr. Matt Grant, who's a palliative care physician and general practitioner, and he's just finishing off his PhD in the whole area of informal communities and their role of how they contribute to patient knowledge, wellbeing, and to care. And also to Dr. Catherine Duchelet, who's a nephrologist and someone with a particular interest in palliative care, whose PhD has been exploring renal supportive care, its practice, acceptability, and its intersection with palliative care. And they are speaking to us on the 23rd of June, same time, 4 p.m. So thank you again, Bruce. Thank you, Stacey and Tanya. I look forward to seeing you, the audience, again, hopefully in about 6 weeks' time. And I wanted to thank you particularly for coming today and for contributing to the chat and for being part of this event. Thanks, everyone.